So this is an anterior left arm, and we're going to have a look at the chords of the brachial plexus. So the clavicle's been cut, the subclavius is cut, and we're seeing the axillary artery here. And relative to the axillary artery, we have the medial cord and the lateral cord. The posterior cord, of course, is not visible because it's deep to the axillary artery. So these cords are a more distal continuation of the brachial plexus. And now we're going to have a look at the major nerves of the arm and the forearm. So the brachial plexus, of course, is not shown here. The brachial plexus is made up of roots, then trunks, then divisions, and then we end up with cords. So cords are named based on their position relative to this axillary artery. Here's the medial cord because it's medial to the artery, and here's the lateral cord, lateral to the axillary artery. And there's a third cord, which is the posterior cord, and that lies behind the artery. So here's the lateral cord of the brachial plexus, and this is made up from anterior divisions of your middle and superior trunk, which are more proximal in the brachial plexus. Now this lateral cord does give off a little side branch called the lateral pectoral nerve, but its two main terminal branches are the ones we're going to look at. So the musculocutaneous nerve, I'll show you. So what we have to do is remove the biceps brachii, and then we can see the musculocutaneous nerve here. And as the name implies, musculo means muscle, cutaneous means skin. So it's a motor and a sensory nerve. So I'll show you the course of it. Here's the musculocutaneous nerve. It actually pierces this coracobrachialis muscle, and then it descends in the anterior arm deep to or posterior to the biceps brachii and anterior to the brachialis. And then distally from there it supplies sensation to the skin over this lateral portion of the forearm. So a good way to remember that is the musculocutaneous nerve supplies the 3 B's. That hopefully doesn't confuse you because one does start with a C, but coracobrachialis, so the B for the brachialis, B for biceps brachii, B for brachialis. So the musculocutaneous nerve is from the nerve roots C5 through to C7, and it supplies the 3 B's, which are shown here. So basically, in summary, it supplies all of the anterior compartment muscles. So the other terminal branch of this lateral cord is the median nerve. And the median nerve is well known for being involved in the carpal tunnel syndrome of the wrist. The median nerve, we would say, arises from C6, C7, C8 and T1. And that's because it has a combination of divisions from both the lateral and this medial cord. So because it receives contributions from both is why we would say it spans nerve roots C6, 7, 8 and T1. So the median nerve supplies nearly all of these flexors in the forearm. So it's a really important nerve. So it's going to supply all of these flexors that arise from the common flexor origin. So here's the median nerve, except for 2 things, except for the flexor carpi ulnaris, because that's done by the ulnar nerve, and also with the exception of the ulnar half of this flexor digitorum profundus. So remember, a digitorum supplies the digits. There's 2 layers, like a spare tire, so you have flexor digitorum superficialis. If we lift that off, we're seeing the median nerve descending here, lying on top of flexor digitorum profundus. But in essence, you can think of the median nerve as the main nerve supplying nearly all of the flexors on this anterior portion of the forearm. So this medial cord of the brachial plexus, we said, arises from anterior divisions from the inferior trunk, which would be more superior, and we can't see that. And it has 5 branches. So we're going to focus on primarily just the terminal branches in the arm and forearm, but those 5 branches include 2 cutaneous nerves which supply the skin, and also one called the medial pectoral nerve. So let's have a look at the terminal branches of the medial cord. So in the arm, we've already looked at the median nerve, and now we're going to be looking at the ulnar nerve. So the ulnar nerve is the second terminal branch of this medial cord. So can you see how the median nerve receives some fibers from the lateral cord? So we say that the median nerve is a terminal branch of the lateral cord and the medial cord. The ulnar nerve is seen here. So the ulnar nerve is coursing down anteriorly to the teres major, and you can see it's medial to the brachial artery, medial to coracobrachialis and biceps brachii. And here it is here, passing now toward the posterior compartment of the arm. And at this location, it's anterior to your triceps, and here it pierces through some fascia to pass posterior to this bony knob, which is your medial epicondyle. And you'll be well familiar with the medial epicondyle. We characteristically bang it a lot and call it our funny bone. So the reason that the nerve refers down to this fourth and fifth and tingles when you bang here is because you upset the ulnar nerve in what's known as the cubital tunnel. So the ulnar nerve receives contributions from the roots from C8 and T1 and occasionally from C7, and its distribution in the hand or the dermatome ends up being this fifth digit and the fourth digit primarily. And the ulnar nerve, when it reaches the forearm, you can see here how it runs adjacent to the flexor carpi ulnaris. So see how this muscle is inserting here on the pisiform? That makes it a flexor at the wrist, not the digits. And you can see deep to it or posterior to it and adjacent is our ulnar nerve. So it's lying posterior to your flexor digitorum superficialis, which is here. And then remember, deep to this flexor dig superficialis, you have a digitorum of a similar name, but this time we call it the profundus. So in terms of what the ulnar nerve innervates from a motor function point of view, it's this one, abbreviated the FCU, and the ulnar half of the flexor digitorum profundus. So remember, the profundus is the one that causes flexion of the distal interphalangeal joints, whereas the superficialis is a flexor of the proximal interphalangeal joints, so the PIP, otherwise known. So I'll point out two tunnels to know. One of them is the cubital tunnel, which we're not seeing, but it's the tunnel that's posterior to your medial epicondyle. And the other tunnel to know, with reference to the ulnar nerve, is this little tunnel here, known as Guillon's canal. So you can see the pisiform bone, and the ulnar nerve is passing into the palm of the hand at the hypothenar eminence, but it passes superficial to this flexor retinaculum, whereas our median nerve passes deep to that flexor retinaculum. So this is the posterior aspect of the arm, and what we want to do now is look at the nerves that supply the triceps area and the extensors of the forearm. So to do that, we'll rotate the shoulder over and we'll look at firstly what's known as the posterior cord. So the posterior cord of the brachial plexus is located posterior to this axillary artery here. So we can see the medial cord, the lateral cord, but the posterior cord is tucked in behind. And the posterior cord receives contributions from nerve roots C5 all the way through to T1. And the posterior cord itself, we would say, has 5 branches, but I'm just going to focus on 2 terminal branches, which are the axillary nerve and the radial nerve. So the axillary nerve, we can see it passing out the back here and emerging at the posterior shoulder. Now we're only seeing it because I've removed the deltoid muscle. So the deltoid muscle normally covers the shoulder like this, but if I remove it, we can see the lateral head of the triceps Here's the olecranon process. Here's the long head of the triceps. And then you can see the posterior spine of the scapula. And here's the infraspinatus. Here's the teres minor muscle. So there's a space known as the quadrangular space here between the long head and lateral head and inferior to this teres. And this is where the axillary nerve emerges. So it's obviously passed through the axilla and now it's emerging. And this nerve supplies the deltoid muscle. So it's a motor nerve to the deltoid muscle. It's also a motor nerve to your teres minor, which is here. And then it's also responsible for sensation over this lateral aspect of the upper arm. Now the quadrangular space is a point where the nerve can become damaged or irritated. I won't go into that too much because I want to get to the radial nerve. So the radial nerve is a terminal branch of the posterior cord of the brachial plexus, and the radial nerve is not seen here because it's running deep to the deep to the triceps muscle. The radial nerve, which also passes through the axilla, is responsible for supplying a lot of this posterior aspect of the arm. So the nerve roots C5 through to C8 and also T1 contribute to the radial nerve. And it really is the largest branch of the entire brachial plexus. So in the front of the axilla, or anterior axilla, this radial nerve descends anterior to your subscapularis and also your teres major. And then as it passes out beyond the latissimus dorsi, we can see, if we removed the triceps, that it enters what's known as this radial groove or the spiral groove. So it's an oblique groove on the posterior aspect of the humerus. And basically that nerve is going to descend posterior to the humerus but anterior to the triceps. And actually the groove forms a small division between the long head and the medial head of the triceps. So the medial head insertion would stop around about here, and the nerve would carry on underneath this long head and then underneath the lateral head as well. So then where do we find the radial nerve? So the radial nerve, while it supplies the triceps, it actually keeps descending into the forearm. So we would see it emerge between our brachioradialis and our brachialis. So if we were to come back to this cubital fossa, you can see the lateral border of the cubital fossa is our brachioradialis, and our radial nerve is going to emerge deep to this. So if I was to remove the brachioradialis, we can see at the cubital fossa the radial nerve is dividing into two branches. So the radial nerve, like most of these brachial plexus nerves, is both motor and sensory innervation. So in this region here, we can see against the radius is a little fleshy muscle here called the supinator, and that causes supination, which is to turn the palm up. And the deep branch of the radial nerve, which is our motor nerve, actually pierces through the supinator and then carries on out to this posterior aspect of the arm, and that's the main motor branch. This little branch here is the sensory branch, so we call it the superficial branch of the radial nerve. And it descends posterior and deep to the brachioradialis muscle all the way down the forearm. So if I was to trace out the superficial branch of the radial nerve, it basically runs in this direction, and then you can see here it's emerging between brachioradialis and the tendons of compartment 1, and you can see it passing here over the snuff box. So the anatomic snuff box is that portion that's bound by compartment 1 tendons and extensor pollicis longus. So around about here on your wrist is the snuff box, and that's where the superficial sensory branch of your radial nerve is located. So that has implications for doing injections of the compartment 1 tendons. Sometimes fractures of the scaphoid or distal radius are also going to affect that nerve. But it's not a motor nerve. The deep branch, which is seen in here, is a motor nerve. And when it passes or pierces the supinator, we call this the arcade of Froese. And sports where they're repetitively supinating and pronating, like if you're on the tools and using screwdrivers, occasionally people develop injury to this deep branch of the motor nerve. But the most common way to injure a radial nerve is with a humeral fracture. So because the nerve passes through this spiral groove and is immediately opposed to the humerus, a midshaft fracture of the humerus can affect the radial nerve. So if the radial nerve was damaged from here down, the typical injury is called wrist drop. So you imagine the radial nerve supplies every single forearm extensor on this side, which is producing the movement of extension. So if we knock out all that and there's paralysis, then people get a condition called wrist drop, which is where the wrist is just in permanent flexion and they're unable to extend it. If we were to injure the radial nerve superior to this level, so up here, we would also lose the function of the triceps and even potentially some of this deltoid muscle is affected depending on whether we're injuring the nerve above the branching of this axillary nerve as well. So on the posterior aspect of this shoulder, we can see the quadrangular space and the axillary nerve emerging with the posterior circumflex artery of the humerus. And then as the radial nerve passes through the spiral groove, it's also accompanied by an artery, which is your profunda brachial artery. And then where the radial nerve emerges is going to be anterior to your lateral epicondyle. So if these are the extensors of the forearm, they're all originating at the lateral epicondyle of the humerus. So where do we find the radial nerve? So we said it's going to emerge between your brachioradialis and your brachialis. So here it is here. So it's actually emerging from the posterior compartment, but it no longer remains in that posterior compartment of the arm. It wraps around, piercing through fascia, and here at the elbow crease it's emerging between brachialis and brachioradialis. So the nerve is lateral to your brachialis. So just remember that your median nerve is medial to the brachialis. Now the radial nerve supplies all of the posterior arm, so the triceps, and all of the forearm muscles, but it also supplies sensation to the skin. So at the lateral epicondyle, that's where it's dividing into its superficial sensory branch and its deep motor branch. Now that superficial branch, as we said, remains underneath the brachioradialis muscle. So it's protected by the brachioradialis all the way to the wrist, where it then supplies cutaneous sensation over this dorsal wrist and hand. The deep branch is piercing the supinator via the arcade of Froese, and then it's the primary motor innervation to all of the wrist extensors or the extensor compartment, but there's also an articular distribution obviously to joints as well. So the median nerve and the ulnar nerve also supply sensation to the elbow joint itself. So they're never just primarily for the muscles, they also innervate bones, which is why fractures hurt so much. The median nerve is seen here medial to your brachialis. Now this is a nerve that doesn't supply any muscles within the arm, so there's no branches within the arm, but then there's multiple branches within the forearm. So the median nerve arises from the lateral cord, but also the medial cord gives rise to this little division. So the median nerve is medial to your biceps brachii, slightly posterior though, and it's running or accompanying this brachial artery. Okay, so this is the ulnar nerve over here. So at the cubital fossa, which is this triangular space here, it descends deep to the bicipital aponeurosis. So I haven't got a bicipital aponeurosis on this model, but here's the distal biceps tendon. But remember, there's also a little fascia that extends over these flexors of the forearm. So the median nerve is protected, if you like, with the brachial artery underneath that bicipital aponeurosis. So here is where the level would be where the median nerve supplies branches to the elbow joint. Now, what would injury to the median nerve produce, or what clinical sign would you see in the hand? So primarily the median nerve is supplying all these flexors except for flexor carpi ulnaris over here and the ulnar half of the profundus. So here's your digitorum profundus. So if you remember the function of this flexor digitorum superficialis, it's to flex the proximal interphalangeal joints. So if we were to completely injure our median nerve, it could produce paralysis or inability to flex digits 1, 2, and 3, particularly at the distal interphalangeal joint, because it does supply the flexor digitorum profundus. So that would look like this, meaning they can't form a fist. So they call it the sign of benediction. Now, at the same time, it may weaken some flexion to the digits 4 and 5 at the proximal interphalangeal joints. But in terms of the distal interphalangeal joints, it would really only affect digit 2 and 3. It wouldn't affect 4 and 5 because they're supplied by the ulnar nerve. So the median nerve also supplies these thenar muscles, and we may see wasting of the thenar muscles, and it's the nerve that we talk about when we mention carpal tunnel syndrome. So sometimes those people have a really subtle flexion weakness, meaning they just feel like their grip strength's weakened, but also sort of a paresthesia or a numbness, tingling feeling of these digits 1, 2, and half of the third. So that's your typical carpal tunnel syndrome. There's also a syndrome called pronator syndrome. We love syndromes, there's so many of them, but your pronator teres is this little muscle here, and your median nerve has to pass underneath it or between two heads of it. So if you imagine tennis players, you know how they have huge forearms and they're constantly top spinning the ball, so they're constantly pronating. So professions like that, where this pronator teres would enlarge and become really bulky, can potentially cause a lot of pain because it irritates this median nerve as it passes underneath the pronator. Now the median nerve gives off an important branch, which I'll mention now, and it's called the anterior interosseous nerve. So the median nerve in this distal cubital fossa would give rise to the AIN for short, and it's a nerve that descends deep within the forearm, and it's accompanied by a small arterial branch from the ulnar artery called the interosseous or anterior interosseous artery, and that nerve is running between your flexor digitorum profundus and your flexor pollicis longus, which is down here, to supply this little square muscle that's deep in against the bone called the pronator quadratus. So if the AIN is injured, occasionally we'll see a symptom known as the OK sign or inability to form an OK sign. So normally people can do this and we say OK, but with an AIN injury, anterior interosseous nerve, sometimes it looks more like that. So these joints collapse in. Now there's a matching posterior interosseous nerve, and we could abbreviate that as the PIN, and we've already discussed it. So the deep branch of the radial nerve, which is here, passes into the supinator, and when it emerges along the posterior aspect of the arm against the interosseous membrane. And the deep branch basically just changes name to the pin. And here it is here, and the pin is the motor branch of the radial nerve that supplies all of these wrist extensors. So the ulnar nerve is seen here, and obviously it's on the ulnar aspect of the arm. And the ulnar nerve arises from what's known as the medial cord of the brachial plexus. So the medial cord is this, and it's so named because it's medial relative to this axillary artery. So in the upper arm, the ulnar nerve is descending anterior to the triceps, and here would be the medial head of the triceps. So you can see the nerve itself relative to these anterior muscles is quite medial, and it's also posterior and medial to the brachial artery seen here. So here's the ulnar nerve. At this point, it is going to pass anterior to the triceps, but then posterior to the medial epicondyle. It's also going to be medial to your olecranon process. So you can see the triceps insertion here. So here's the ulnar nerve. Now there's no branches within the arm itself. It's primarily on its way to the forearm. So it enters the forearm through flexor carpi ulnaris. So here's the flexor carpi ulnaris insertion. Here's its origin at the common flexor origin, or the medial epicondyle. So can you see how the ulnar nerve is piercing deep to flexor carpi ulnaris? And in fact, the nerve stays deep to the flexor carpi ulnaris and adjacent to it all the way down the forearm. Now, the ulnar nerve is also going to supply the medial skin of the hand and also the third and the fourth lumbricals. So the lumbrical muscles are intrinsic hand muscles, and primarily it's acting on these distal interphalangeal joints of the fourth and fifth digit, because that's where flexor digitorum profundus tendons insert. They insert into the distal phalanx. Now, in case you're confused about what the cubital tunnel is itself, the cubital tunnel is bound by fascia. So it's between the olecranon and the medial epicondyle. And sometimes there's a little fascia over the top known as Osborn's fascia. Now the ulnar nerve is fairly exposed at this point, so when you lean on a table or bang the ulnar nerve, you know about it, and it sends sort of a radiating tingly pain down to your fourth and fifth digit. But in some people, they actually have accessory muscles or bones or ligaments at the cubital tunnel, which cause compression of the ulnar nerve. So the medial head of the triceps itself can enlarge to the point where the ulnar nerve no longer fits in the cubital tunnel. So we see this in people who go to the gym a lot and perform tricep dips, become very enlarged in the medial head of the triceps, and sometimes that's enough to cause irritation of the ulnar nerve. And ulnar nerves are very prone to subluxing, so they can flick in and out of the little tunnel between those two bony protuberances. And the flicking itself is not a problem, it's very normal, but when the flicking starts to irritate the nerve and people are actually getting ulnar nerve symptoms or sensations in the hypothenar eminence, that's when sometimes ulnar nerve fixation surgeries are performed. Now I'll just finish by discussing what the cubital fossa actually is. So the cubital fossa, what we need to do is draw an imaginary line from the medial epicondyle to the lateral epicondyle. And then you can see here two muscles either side. So on the medial side we have the pronator teres, and on the radial side or lateral side we have brachioradialis. So that's the boundaries of the cubital fossa. So we have lateral epicondyle, medial epicondyle, and then we could say that the roof of the cubital tunnel, the cubital fossa, is the deep fascia of the arm, and the floor is the brachialis muscle. And there's obviously several contents, we've discussed some of them, one of them being the brachial artery and also the median nerve, and then there's also superficial veins that course across that cubital fossa.